Welcome to the Releaf podcast, where we explore the science, stories, and breakthroughs shaping the future of medical cannabis. I'm Graham Woodward, Chief Operating Officer here at Releaf. And today we're joined by someone whose work has made a real difference to patients across the UK, Dr. Katrin Schlag. Anne is Head of Research at Drug Science, the UK's leading independent scientific body on drugs. She's played a key role in building the evidence base for medical cannabis, turning lived experience into real-world data and helping ensure patients' voices are heard where it matters the most. In this episode, we talk about why patient-reported outcomes are so powerful, how evidence drives access and acceptance, and what's next for medical cannabis in the UK. Anna, thank you again for coming today. Lovely to see you after all of this time. I wonder if you could give us a little insight into the work Drug Science is currently doing.
Yeah, hi, Graham. Thanks for having me. And I want to just give a very brief overview of Drug Science, a charity founded by Professor David Nutt in 2010 upon his sacking from the ACMD, the Advisory Committee on the Misuse of Drugs, when we published our first multi-criteria decision analysis comparing the harms of various drugs, including, for example, cannabis. But obviously, the key controversial aspect was that alcohol came out on top of all the harmful drugs in terms of harms to the individual as well as to society, and the so-called illegal drugs, including cannabis and the psychedelics such as LSD and psilocybin, came out way lower. So this was obviously quite a controversial finding, which led David Nutt to be sacked and start Drug Science. So since that time, we've continued to really advocate for telling the truth about drugs and really providing this scientific evidence to impact policy making and better decisions. And as we've worked together in the medical cannabis space, that's obviously very evident in there. With the rescheduling of cannabis as a medicine in 2018 here in the UK, came really the need to make medical cannabis accessible for patients, and we've worked together on that. And so we started our medical cannabis working group, and from that came T21, our real-world data registry.
I remember being part of the original T21 data capture, which was really exciting. And I know you've had many publications out of the data that you captured. Can you give us some more insight into where we are today with T21 and the data that you captured?
Yeah, absolutely. So we've had loads of publications, and for the listeners interested, please check our webpage. They're all available online on the Drug Science webpage. There are loads of publications forthcoming as well. T21, after a successful 5-year run, concluded in December 24. We have nearly over 5,000 patients who went through the register and provided their data on various conditions. And yeah, it has certainly been a very, very successful project.
What were the key findings from those publications? I think that was really key to see. Was there an outlying patient group that wasn't captured or served, you think, with the current service provision that we have?
Very good question. So key finding, I think, for me personally, was just a very general thing, so not condition specific, the improvements in quality of life which patients saw, which I think is very exciting because it was across the board, across different conditions, across different age groups as well. So, and this, as we all know, is a key aspect in whether it is pain related or multiple sclerosis or cancer related issues and so on. So quality of life of patients is a key issue. So that was an interesting finding also, that this quality of life continued to improve after, for example, 3 months and so on. And it, these were longitudinal findings, which again is very important really, as you know, to see. So this was very positive. We have, in relation to pain, I think it's very, very exciting too, that we have seen immense improvements in various pain conditions. So for pain, it's not just chronic pain, but can be various neuropathic neuropathic pains, fibromyalgia, Crohn's disease, and so on that were included in our patient cohort there. So this was very good. And in line with the prescription of medical cannabis, we've seen significant reductions in opioid prescriptions, as well as other medications. But obviously, what patients and many doctors these days are concerned about is quite an increase in opioid prescription for chronic pain conditions specifically. So this, I think, is very positive. Again, going a step further with the decreased opioid prescriptions, we also saw, again, improved quality of life, because patients seemingly are able to deal better with the so-called side effects of medical cannabis than those with various strong opioids. So I think that is, some very exciting findings.
Yeah, we're trying to encourage our patients to report to their opioid prescriber, whether that be a pain doctor or a GP, to report that back so that we can promote even more so the benefits of medical cannabis. We've also just introduced 15 patient disease-specific validated screening tools into our platform, such as EQ5D, as you say, GAD7, ISI, et cetera. How important do you think all services should be introducing screening tools into their everyday practice?
I think that it is very important, and maybe I should have said this, obviously within T21, in order to collect the data in a rigorous and systematic manner, we use exactly these kind of externally validated tools for various conditions, whether it's the pain index, the GAD7 for generalized anxiety disorders, and so on. So I think this is really important to do this, and also obviously to then see and study patient-reported outcomes. So you can, validate this over a longer period of time. And I think that's a really great thing. And we at Drug Science, we'd be very happy to support that.
Yeah, well, we can have that discussion, and we'd always welcome that. We've had a discussion with Johns Hopkins University in Baltimore, and they're really keen to share data of the work that they're doing as well. So we're really excited about this. Affordability for patients. Obviously, a lot of patients have either on low incomes due to their condition. What do you think that needs to change at a government level, a policy level, to make medical cannabis treatment more accessible for patients who are still unable to access treatment?
Yeah, this is a key aspect, as you know. So I don't know the costs that you're charging at the moment, but as you say, for patients on disability benefits or elder patients who do not have an income as such anymore, unfortunately, the private prescriptions are still out of bounds, especially because a lot of these patients have chronic conditions, so they need the prescription for years, not just a few weeks. So this is for many people, this is a substantial cost, which obviously impacts the affordability. So on the government level, and Drug Science is doing a lot of work in that too. So really, one of the key aims of T21 was obviously to collect the data, to analyze it, publish in the peer-reviewed literature, as we have done and are continuing to do. But also the other overarching aim is really to impact policy making and influence the key decision makers in that, who have so far, as you will know, generally only given the importance to RCTs, randomized controlled trials, which in terms of various medical cannabis prescriptions as well as conditions is still lacking. But the real world evidence, we think, by now speaks for itself, so that cannabis should be made more widely accessible on the NHS, on the National Health Service here. As you know, at the moment, the conditions for which cannabis is recommended to be prescribed by NICE, the National Institutes for Care and Excellence, are still very limited, restricted to the 4 key conditions. The number of medical cannabis products is also still very limited, excluding, for example, various flower products, which many patients are particularly keen on for various reasons. So this remains an issue, and we're hoping to do the research to move the evidence base forward to actually impact the policy making. But this really needs to change. So we would suggest the NICE recommendations would need to to change, to include greater range of potential conditions. Key area there would be pain. I mean, in most areas of the world, medical cannabis when it can be prescribed, medical cannabis can certainly be prescribed for pain or chronic pain conditions, which is a huge cohort in most countries, obviously. So this is, it's frankly ridiculous that it cannot be prescribed, but that opioids can be prescribed for pain patients.
Amazing. I think we're completely aligned on this, aren't we? I think the other barriers that we still are up against and patients are still up against are the fact that patients have to evidence that they've tried or had 2 previous treatments before being able to access our services. I spent quite a bit of time following David Nutt around the country doing his educational events and tours. I remember being in Edinburgh, and he was always, of course, David's presentation and his knowledge is astounding. It's something I'd aspire to, I think, to some degree. However, I think all of that work that he did going around the country doing educational platforms, a lot of the doctors that I met and nurses that are now current prescribers for a lot of the services all attended those events. And I met some great doctors who approached me after your drug science kind of roadshow, as it were, that have now become prescribers. What's your plans going forward? Are you still going to do those events, or have you got more planned in the future, or have you stopped those?
So we would love to do more of those events, especially also presenting the new T21 data. Very much depends on funding, unfortunately. This was all part of T21 and kindly sponsored by the consortium of industry partners that we had then. And since the project concluded, we don't quite have the resources to do as much outreach. As you say, it's very important, but we're quite limited in that. We do still run our medical cannabis working group, also chaired by David Nutt, with various industry partners, patient representatives, policy specialists, and so on. So then we are always looking for industry partners to support our work in that. And with this, the funds raised through this, of course, we can do more road shows, more publications, reports, and so on.
You mentioned when before we became on air, that you thought Releaf should be part of your medical cannabis working group. Can you give us more understanding of what the work is and what you're doing, and who are the participants of that currently?
So we have, some key partners involved in that work. It is led, obviously, by the scientific expertise, by David Nutt, Val Karen, and people who have been working in the medical cannabis space for absolute ages, taking now a bit more of an international outlook, having some of the, German partners and so involved, obviously, going on there. We meet twice annually at the moment, online, just for ease of convenience, basically. Have keynote speakers, very exciting one. We had Didi Mary from Israel, for example, recently. And the speakers speak whether it's new advances in cannabinoid medicine as such, but also new advances in policy making and regulations and so on. So that's quite a broad aspect. In addition to that, we have key decision makers such as Baroness Molly Meacher or MP Jeff Smith, who are really in the deep of things, who can advise us and who join the meetings. And then, very important, we also have our patient representatives.
Very exciting indeed. Do you think, as patient numbers are definitely growing, I think they've had another surge in this year particularly, and there's more and more doctors coming to prescribe medical cannabis, which is, again, incredible, and it's really good for us, for our organization and for the patients as well, to have access to as many consultant disciplines as there are out there. Do you think that medical cannabis should be part of a core competency from medical school or nursing school or even pharmacy training?
I think so. I think there's absolutely space for that. And again, we've actually developed the modules at Drug Science already. At the moment, they're freely available on the webpage, and we're actually trying to get them into a curriculum, university curriculum, which isn't as easy as you'd like to think, because obviously, as you will know, so far, we hope it's changing. And it is already changing and other constituencies. Medical cannabis was really presented more in terms of its negative impact on health, in terms of addiction, recreational use, and the dangers of drugs. This kind of narrative, and it is important for doctors or for other healthcare providers really to learn more about it and to learn about the more positive aspects where it can help, to actually learn much more about the whole endocannabinoid system, which is often a neglected area as well. So yeah, we're working on that, and as you say, we have more doctors as well as more kind of academics who are interested in moving this forward as well. I think this is important for medical cannabis to become basically a medicine again.
Yeah, I think we should be working more closely together at how we signpost to the training that you offer. And I think that we, as organizations and services, it's our responsibility to provide as much education as we possibly can. And I know that you have looked at, obviously, Canadian prescribing and practices and German practices. What do you think we could learn from other territories in the UK that we could adopt here?
I think what I mentioned before, the lack of prescribing for pain conditions is a serious issue here. And when doctors, and I know a few kind of formally, when they actually look at what's being prescribed for pain, for example, whether that's in Germany, US and Canada and so on, they do find it very interesting. And also within T21, the pain conditions, the pain cohort was always the largest cohort of patients. So as I said, it's silly just not to prescribe. But so this is absolutely a key area. And I think looking, at more detailed strains or more detailed different cannabis products, I think, also there's some things that can be learned from other countries who have possibly prescribed a bit longer or a bit wider than we have here.
And some clinics struggle to balance compliance with really patient-focused care. How do you think we can address that?
Good question, and I'm not entirely sure because I'm not in the
tricky question.
clinic
I know,
area.
It's a difficult one to ask.
But obviously, the patient care has to come first. I do also understand, patients have strong views on certain things, and rightly so. We do have many patients who on the one hand know what they want already. And then we have other patients who are also completely naive. So I think as a prescriber clinic, you have to be able to deal with both. And I think that's where cannabis is, for example, different to other medications.
Yeah, that's a fabulous answer. I'm going to make it an even more tricky question for you now. So if you were to design a ideal, perfect treatment provider or treatment center, what would be the 3 things that center or that service would need to provide?
So reimbursement through the NHS or another route, as we have in Germany, for example, but I think here it would be the NHS here in the UK. I think this is absolutely a key aspect. The ease of access, for which actually through telemedicine, many patients have been able to secure. So it's not that it has to be a Harley Street clinic or anything like that. And then both the specialisms of the doctors, whether it's the pain, we've spoken a lot about pain now, but the other huge area that I think has been quite neglected is anything related to psychiatric conditions. Right. The patients can be insomnia, depression, PTSD, anxiety disorders, possibly addiction symptoms as well. So that's to have a psychiatrist as well, so a pain specialist, a psychiatrist, and then ideally somebody who can actually also deal with more rare diseases such as Ehlers-Danlos syndrome, various specific treatment-resistant epilepsies, and so on. And they have an array of products for this condition. So it's quite a big ask, I think.
That answer works perfectly because everything that you mentioned in the 3 additions that we should have as a clinic, we're on that track. So that's brilliant that you've and we didn't obviously have that discussion before this question came up. So I'm very proud that we are moving in that direction.
Yeah, I think it's important. You want to be able to offer the best, and I think from my kind of science perspective, I would also like to see a clinic with a full large-scale data registry, really documenting, doing rigorous research, and systematically collecting the data of a longer period of time as well. And this is obviously again related to the specific outcome measure, patient-reported outcomes, any adverse events as well, so that we have this data. Whether it's going to be published or not is a different matter, but I think it is really important to actually have this data systematically collected. Ideally, I'd like to see different clinics or different providers collect the same data, because then, you might have 10,000 patients, another has 5,000, another has another 10,000. This is then automatically a huge database, which is, for us as researchers, very exciting.
Yeah, I think that's why we're really excited to be working with Johns Hopkins, because they're doing a very similar data capture to we are. I think there's a crossover, at least of 75% of the validated tools that we're using. They're doing, obviously, their cohort of patients, they're doing a USA-wide data capture. We've got circa 10,000 patients. So I wonder if we could call on you and...
Yeah, we'd love to. We'd love to be involved.
Amazing. That'd be amazing. And of course, we're still up against the stigma of cannabis causes psychosis, which we're working hard to dismiss that. And it is, as you already mentioned, with the super skunk and things that are grown or sold recreationally, there is a risk and predisposition, of course.
Yeah, absolutely. So there's a risk if people are predisposed. And again, this is why we have certain exclusion criteria in the research and in the patients so far, but we need to do more research in this particular area, especially if possibly a CBD dominant product can actually still be used, can still even be helpful and so on. So I think we do need to distinguish between even though it's overlapping and to some extent, obviously, between the recreational and the medical use and users as well, using for, different products for different purposes, different dosages and so on.
Many people, as you know, are still unaware that medical cannabis is legal and available to be prescribed. How at Releaf can we break down, what can we do education-wise or any other ways to help that message to get wider across the population of the UK?
Good question. And we're working on that as well at Drug Science. And together with, I should mention, the Medical Cannabis Clinicians Society, which is providing education to doctors and other healthcare professionals. But as you say, the medical cannabis also has to go out to the broader public, decision makers, and so on. And there's a lot of education that still needs to be done, as you say, despite the legalization of medical cannabis in 2018. I think about half the population, I'm not exactly sure what the percentage are still not really aware that medical cannabis is indeed legal to be prescribed here in the UK. So we often get, surprised people and so on when we speak as well. But so more needs to be done, much more public outreach. We obviously publish in the scientific literature, which is great, and we need the scientific evidence, as you know, but we also need to, speak to the general public and publish in the much broader literature, TV as well, for example. And again, just to, wanted to go back to Hannah Deacon, who's probably done more for medical cannabis than most of us have done together for the acceptance and availability of medical cannabis here in the UK, just by being out, putting herself and her son forward, speaking about medical cannabis, campaigning for patient access, being on whether it is radio, news, TV, BBC, and so on. I mean, so this is key in terms of also having, the patient narrative. I think patients can do quite a lot, I think, themselves, if that's what they want to do. Lucy Stafford is another example, and really putting their stories forward, because that's what most people can relate to. I mean, who couldn't relate to Hannah Deacon and her very ill son, Alfie? So this is kind of, in addition to the science, we do need the patient stories. They carry a lot of power and in order to change the narrative.
Here at Releaf, we're launching a campaign based on historical facts that aspirin and penicillin were met with both skepticism because there were no clinical trials. that's the campaign that we want to roll out using that analogy.
I think that's a great idea. And that's the analogies that Professor David Nutt also always uses. And he highlights that especially in relation to penicillin, if we would have waited for randomized controlled trials before introducing this as in medicines, millions of people would have died. So I think this is, it's a key thing to introduce this. And I think what is also valuable to add is that medical cannabis indeed used to be a medicine, and really what we're going through at the moment is just a reintroduction of medical cannabis in the medical space here in the UK. In the past, for example, Queen Victoria used medical cannabis products to aid her period pain and apparently during childbirth. So, it is medical cannabis isn't actually a new drug in there. It's just needs to be, it's being reintroduced really.
Anna, as always, it's a pleasure talking to you. It's been a while and great to see that the work of drug science is still progressing. And we really will take you up on the support with the data. We're in the early days. We've been capturing the data now for just a couple of months. But the data that we're getting so far is very positive. So we'd like to share that. And as I said, we're working with Johns Hopkins as well. So there could be a 3-way collaboration.
We'd love that. We'd love that. Yeah, absolutely. And I think we can add a lot. And as I also said, if the data is collected systematically and rigorously, and ideally the databases of US and UK, possibly other countries, are matched or comparable, then we have an even bigger and better database.
Thank you again.
Thank you.
Great seeing you today.
Okay. Thank you, Graham.
Thank you to Anne for sharing her expertise and for helping us see how data, research, and patient stories can come together to drive real change in medical cannabis care. If you found this conversation helpful and want to learn more about how we're supporting patients with safe, effective, and evidence-based treatment, visit us at releaf.co.uk and subscribe to this podcast wherever you listen. At Releaf, we believe that better health starts with listening to science, to clinicians, and most importantly, to patients. Thank you.